Well, Don, there were a number of changes that we had to make, but we were really driven to make changes in our practice to address the barriers that we faced as physicians on our way to becoming more accountable for quality and cost. So we about 10 years ago, we had a plan of, really it was a 5-point plan. It was to streamline processes, to get rid of valueless variation in the way that we deliver care. It was to standardize roles and responsibilities to create a consistent care team at all of our 3 sites of operation. It was our next goal was to engage patients and their families more fully, make them more aware of their situation, get them involved in discussions. The 4th goal was to minimize clinically irrelevant physician activity, take the time wasters away from the physicians and let them become what they went to medical school for, which is complex medical decision makers and maintainers of personal relationships. And the 5th thing was to fix accountability for performance at the locus of control in the care team. So we added a few more things. We started to do that, and we added a few more things. One is a data system to collect data so that we could commit to a continuous process of improvement. We thought that the answer to our 5 targets would be solved by an EMR. It wasn't. So we incrementally developed a software overlay to meet those 5 goals, and that gave us also a data collection system and allowed us to be committed towards continuous process improvement. So we did that without any knowledge of what the medical home criteria or standards were, because they weren't even developed yet. And we turned around in 2008 after we saw that we drove consistency of care, quality, and we started to see cost coming down. That's when we realized we met the criteria for patient-centered medical home recognition.